Okay, good evening, sir, and good evening to all. Uh, so today I will be talking about dialytrauma. So, what will be talking on what is dialytrauma and how it has been introduced and what all things includes in dialytrauma and how we can manage for the dialytrauma. So, uh, we all know that CRRT is the now the leading form of renal replacement therapy in acute kidney injury in ICU patients worldwide, and there are multiple practice variations in the application of the CRRT. Uh, Moving to this because there's no clear evidence-based guidelines for the CRRT applications. Up till now, we have two large multicentral RCTs which have established that increasing dose of renal replacement therapy, that is above an effluent flow rate of 25 ml per kg per hour, is not beneficial. And the CRT is now widely accepted as the most appropriate therapy for vasopressor dependent patients who require renal replacement therapy uh, in patients with acute kidney injury in the ICU. Still, there are some number of aspects of the CRT which require further research, particularly threshold, optimal threshold of the CRT and the timing of the CRT. So, status of the issues concerning the renal replacement therapy use in the ICU is first the CRRT dose. It is a kind of resolved, but still in favor of conventional dosing with target effluent flow rate of 20 to 25 ml per kg per hour. This CRRT, then CRRT versus intermittent hemodialysis. The consensus is in favor of CRRT in hemodynamically unstable, critically ill patients, but this not the formal evidence is available. Timing of CRRT is still unresolved issue that requires further research. Then CRRT outcomes. This it is unresolved issue. The studies to date may have been too focused on mortality over renal recovery and other patient-centered outcomes, but not all the outcomes. And CRRT modalities, still it is unresolved issue. As we see in some studies, as there's one study in Taiwanese multi-center study. So this study is a multi-center retrospective cohort study in which they have studied almost 9,500 patients from the hospital from the Taiwan from duration 2009 to 2018. And they measured this ICU mortality and dialysis treatment at the discharge among the hospital survivors, and they found that there is decrease in the mortality in ICU patients with dialysis treated AKI patients from 2009 to 2018 even after adjusting for the dialysis dose and the severity of the illness. And they observed that this ICU mortality, as we can say, the ICU mortality is decreased over the period of time, but this increase in the dialysis treatment at the discharge among the survivors. They observed this trend in the mortality remained statistically significant. Then there's another study, which is the systemic review and uh, meta-analysis, which included almost 11 studies with almost 2,700 patients. And this indicated that uh, CKD, then CRRT duration, and urine output uh, at the end of the CRRT were the predictors for the short-term successful winning from the CRRT. But uh, the other variables like hypertension, use of vasopressors or inotropes at the start or at the end of the CRRT, or use of diuretics at the cessation of the CRRT and serum creatinine at the cessation of the CRRT, they could not found the association, and we need further large prospective studies to clarify this association. Then another study from the Poland hospital, which studied about the mortality of the patients in acute kidney injury patients requiring renal replacement therapy in the critically ill patients. So they found that this acute kidney injury in critically ill patients has deleterious effect on the prognosis, especially when these patients require renal replacement therapy. And this was the observational multicenter study, and the study you outcome in the form of Apache scores. So in this study, they found almost 43.9% mortality in AKI patients, in critically ill patients who required renal replacement therapy. And this mortality was higher in AKI, AKI patients who required renal replacement therapy compared with the other ICU patients who required renal replacement therapy. And they also found this Apache score underestimate the mortality with consideration to acute kidney injury patients requiring renal replacement therapy. They found this use of catecholamines, often the status of the patient in the ICU, circulatory insufficiency, infection, and multi-organ dysfunction, multiple trauma as the independent predictors for the mortality in patients with AKI requiring renal replacement therapy. Uh, there was another study which showed this delivered dose of renal replacement therapy and its association with the mortality in critical ill patients with acute kidney injury. So in this study, they found that the patients who received CRRT and the median dose delivered for the CRT was 27 ml per kg per hour, and for the IRT the dose was 7 sessions per week. So this multivariable analysis, there was no significant association between renal replacement dose and ICU mortality. They also observed in the survivors that shorter ICU stay and the duration of the mechanical ventilations were observed in the more intensive renal replacement therapy groups. So as we see, like here, the dose of the CRRT should not be more than 25 to 30 ml per kg per hour. So we are going towards low dose renal replacement therapy. So this validity of low efficacy continuous renal replacement therapy was studied in critically ill patients. So they found if the lower limit of the CRRT intensity was to be defined by the limit of solute control, then this would seem to be somewhere around 10 ml per kg per hour. The adequate treatment for the acute kidney injury probably does not merely mean that small solutes such as urea should be intensively removed. And this kidney is a very complex organ which sustains homeostasis with many vital roles, as often mentioned in the chronic kidney disease literature, but we are very not much known about its multifunctional role in the AKI setting. So there's another trial, ELAND, a very famous randomized clinical trial, which showed the effect of early versus delayed initiation of renal replacement therapy on mortality in critically ill patients. So they have studied the 90 days mortality in early initiation of the renal replacement therapy and the delayed uh, renal replacement therapy, and they haven't found that much uh, difference as in ELAND randomized clinical trial. So this continuous renal replacement, the complications associated with this are um, start from the vascular access and the patency of maintenance complications. Then there will be electrolyte acid base disorders, normoglycemic ketoacidosis, hematological complications like bleeding, or temperature irregularities like hypothermia, then volume related cardiac stunning, nutritional and physical deconditioning, and the drug clearance. So the complications with the CRRT are related to the vascular access. I'm not going in detail with all these things because with the last lecture we have studied with this vascular access, then extracorporeal circuit with air embolism, then reduced filter life, reduced dialysis dose, hypothermia, and then hematological complications like hypocalcemia, metabolic alkalosis, hypernatremia, citrate intoxications, then heparin-induced thrombocytopenia, bleeding, then hemolysis, then electrolyte-related, nutritional-related complications. So there are a lot of adverse events during CRRT, as we see. Catheter-related complications like hematoma, bleeding, puncture, line-related infection, then hypotension, hypothermia, cardiac complications like various arrhythmias. So, despite the standardized order set in a tertiary medical center, clinically significant hemodynamic, mechanical, and biochemical complications of CRRT are common in adult critically ill patients. Although the extent of to which these complications are attributed to CRRT is not known, still we need to be cautious and aware about their high prevalence in these patient populations. And future studies should focus on this clinical significance of these events and possible modifications to prevent them. So to handle this CRRT related adverse effects in intensive care unit patients, this Menor Moliner has developed the concept of dialytrauma. So the CRRT, the dialytrauma is this newly proposed concept that encompasses all harmful adverse events related to the CRRT. So there will be this can be multifaceted, primarily caused by overly ambitious effluent rates, then electrolyte imbalance, then heat dissipation, loss of carbohydrates, nitrogen, then water soluble vitamins, trace elements. Then this particularly there's the risk of antibiotic underdosing, resulting in failure to attain pharmacodynamic target and leading to higher mortality. Therefore, this requires better understanding, early detection, and management and possible prevention. So the CRRT studies in the ICU patients, they emphasize the positive correlation between hemofiltration dose, the frequency and magnitude of such losses, all of them being potentially harmful if not timely recognized and uh, corrected. So this CRRT trauma, which is dialytrauma, encompasses acid-base disorders, but also loss of heat, electrolytes, carbohydrates, nitrogen, water-soluble vitamins, trace elements, and particularly antimicrobial drugs. So the septic patients in the ICU are a specific for the dialytrauma as they generally receive higher CRRT dose and longer treatment duration and often have depleted macro and micronutrient stores, and they face a worsening of septic process when antimicrobials become underdosed. That's why the dialytrauma is important to detect early in the ICU patients. So this Spanish physician Menor Moliner, he has coined this term dialytrauma, trying to integrate several complications of high-dose renal replacement therapy in ICU patients. This consists of multiple things, but not limited to hypotension, arterial hypotension, then metabolic complications, then hemorrhagic complications, infectious complications, hypothermia, and maladapted drug doses. So it is a mixture of potentially fatal consequences. So these contributors for this renal replacement trauma, maybe the trace ailments, the drugs like antimicrobials, then vitamins, electrolytes, then filter associated, which may cause microinflammation, then catheter associated, like bleeding, infection, pneumothorax, then central vein thrombosis, and hypotension, which may cause lead to non-recovery from AKI. So it is probably not the dialysis dose that makes the poison, but rather the lack of dose adjustment of antibiotics and nutritional support that adversely affects the outcome of our patients. So this hypothesis highlights the urgent need to adjust our old antibiotic dosing schemes to the high efficiency of modern renal replacement therapy in the ICU. And observed hypophosphatemia could be the useful as a warning sign that should prompt re-evaluation of drug doses. I will explain this in further slides. So the numerous pieces of a complex treatment puzzle require excellent synchronization in order to prove or to pivot if a thing such as renal replacement trauma really exists. So, is the lack of survival difference between high and low dose CRT due to excessive antimicrobial removal or to inadequate cytokine clearance? So, higher dose CRT has consistently been shown to remove significantly more small sized molecules such as ions, creatinine, and many antibiotics. In contrast, middle and large size molecules, including many inflammatory cytokines, tend to adhere to the dialysis membrane and they are not removed. With ongoing CRRT, this can be adhere as a protein cake, which is gradually formed on the inner part of the membrane, obviating this passage of these molecules. For a given patient's weight, it can be assumed that higher CRT doses are associated with less optimal filtration fraction and thus more filter constraints and shear forces, as we have seen in the previous lecture also. So doubling the CRT dose did not simply cause a proportional mathematical increase in mediator removal, not achieving doubling of the mediator removal, but much less. Citrate strikingly reduces the rate of membrane clogging. Still hypothetical, citrate anticoagulation may be an attractive alternative for heparin in that it allows easier and earlier passage of middle and large size molecules during high dose CRRT. So this hypophosphatemia, a quality indicator of ICU care rather than the coal mine canary for CRRT trauma and antibiotic underdosing. So hypophosphatemia incidence ranges between 10.9 to 66%. This hypophosphatemia did not emerge as a surrogate marker of significant antimicrobial underdosing. It indicates rather a lower quality of ICU care related to insufficient preventive measures. So the phosphorus should be checked at least twice daily during CRRT and substituted when needed. Not only the dose, but also the duration of the CRRT thus affects phosphate levels. Phosphate transfer during in IST session was little more than half of one observed during 24 hours CRRT treatment, despite it has fourfold higher clearance. So hypophosphatemia is an important determinant of CRRT trauma, but preventing or correcting this deficiency does not at all influence antimicrobial dosing. Other markers to assess the antibiotic dosing should be employed, like direct measurement of plasma levels of antibiotics. So CRRT is not a hurdle for adequate antimicrobial dosing, but rather a shield allowing higher antimicrobial dosing at less toxicity risk. So several studies underpin the potential risk of antimicrobial underdosing during CRRT treatment, which further increases the CRRT trauma. The CRRT allowed the administration of substantially higher doses of antibiotics as the loading, for example, as the loading dose of amikacin, maybe up to 30 to 35 mg per kg, and the maintenance dose of colistin. The CRRT is paradox exists as the technique may promote antimicrobial and underdosing, while at the same time permitting the use of higher antibiotic doses for some antibiotics at less risk for side effects. So what all factors which affects this antibiotics or any other drugs pharmacokinetics while on the CRRT, back to the basic again, uh, like protein binding, drugs that are highly protein bound like in warfarin, diazepam, propranolol, phenytoin are only cleared by renal replacement therapy in small amounts. However, as the patient's protein levels fall, the free fraction of this drug increases, and so does its clearance. Then, size of the drug molecule and mode of renal replacement therapy. Small molecules are cleared by all types of renal replacement therapy, but as molecule size increases, diffusion becomes less effective. Then, timing of renal replacement therapy. Drugs given between sessions of IST or SLATE will not be cleared until the subsequent session. Then dose of renal replacement therapy. The reduced flow rates or shorter sessions will reduce the clearance of the drugs. Then membrane permeability. The high flux hemofilter membranes used in the CRRT are permeable to most of the non-protein bound drugs. Then patients residual GFR should also needs to be taken into consideration. So all the factors which contributes to the difficulties in establishing precise guidelines for antibiotic dosing in critical ill patients are differences in baseline characteristics like age, sex, body mass and surface, fat tissue and muscle tissue content. Then altered drug pharmacokinetics like changes in volume of distribution, hypoalbuminemia, changes in renal clearance, commonly observed disturbances in drug metabolism like in the liver, then dynamic changes in the patient's state, clinical state or organ function. Then renal replacement therapy techniques, their modification, differences in ultrafiltrate dialysate flow rates, then various dialysis membranes and varying treatment times. These all factors contribute to deciding in difficulty in deciding the precise guidelines for the antibiotic dosing. So the drug dosing approaches for this patients receiving CRRT in AKI patients. So ESRD dosing recommendations should be used only as an initial guide for the initiation of therapy in an AKI patient receiving CRRT when no other information is available. The existing maintenance dosing recommendations often result in the achievement of subtherapeutic concentrations and treatment failures for the patients with severe AKI requiring renal replacement therapy. The most effective dosing optimization strategy is to use TDM for the drugs like aminoglycosides, vancomycins. However, very few drugs have clinically useful turnaround time assays available. Then when CRRT or dialysis clearance that are available, the current literature recommendation should be the logical starting dose for the therapy. So different treatment intensities for CRRT or ADT result in marked variability in drug removal, and thus literature may not be generalizable across the multiple CRRT prescriptions that we use in practice. So we can calculate the total creatinine clearance based on the addition of patient's residual renal clearance and expected extracorporeal clearance. Using this method, most drugs will fall in the creatinine clearance of 25 to 50 ml per minute per day. So the dose of those drugs and dosing interval for the patient for a patient with a GFR less than 10 ml per minute, like anuric dose. This makes doses adaptation based on the drug fraction expected to be removed by extracorporeal therapy. So maintenance dose is equal to anuric dose divided by 1 minus fractional dose by extracorporeal therapy. And this dosing interval can be like anuric dosing interval into 1 minus extracorporeal fractional dose of the drug. So, drug dosing approach 5, this starts with the normal dose and reduces the dose based on the normal clearance, effluent rate, and the renal clearance with the sieving coefficient. We can calculate the dose of the drug for the CRRT. So, the recommendations for this to guide this drug dosing during the CRRT is loading dose does not require adaptation for extracorporeal removal, but for differences in volume distribution. We can adapt maintenance dose to the reduced renal function according to the drug information and increase the maintenance dose in patients with AKI receiving renal replacement therapy when extracorporeal clearance is clinically significant, that is more than 25%. Select dose based on the published data. We can select dose based on current creatinine clearance. This does not apply for the drugs with tubular secretion or reabsorption, like in fluconazole. The dose must be increased because tubular reabsorption is absent in AKI and renal replacement therapy. Then calculate the empirical dose as normal dose multiplied by current clearance fraction. Then this drug plasma levels can be, we can monitor this drug plasma levels, and these recorded levels must guide the dose accordingly. That is dose equal to target plasma concentration into clearance into timing. So always bear in the mind that the higher the dose, the higher the need to counterbalance the drug losses. Then there is nutritional and metabolic alterations happening during the continuous renal replacement therapy. So loss of macro and micronutrients is well documented during CRRT. And in general, this requires replenishing or compensating the deficits. The final aim should be to optimize the nutritional status of the patient and to reduce so-called dialytrauma induced by CRRT. So daily recommended energy requirements during CRRT fluctuate between 25 to 35 kilocalorie per kg and between 1.5 and 1.8 gram per kg of protein. The current guidelines allow us to adequately supplement the important micronutrients such as amino acids like glutamine, water soluble vitamins, and the trace elements. This recognition of dialytrauma and the use of appropriate checklists may help the bedside clinician to better assess and handle nutrition deficit in CRRT patients. So, while assessing the nutritional deficits, we should do the metabolic screening for the patient, whether there are depletion of intracellular resources which cause refeeding syndrome, are there calorie and protein requirements due to under or overfeeding, then water causing hypervolemia, then electrolyte abnormalities or deficiencies like potassium, magnesium, phosphate, and the acid base disorder, glucose, lipid, protein. We can monitor all these nutrition related parameters to prevent the nutritrauma during this CRRT treatment. So this need for this medical nutritional therapy after assessment of the nutritional risk in the patients. So how the fluid prescription and removal need to be adapted during CRRT. The fluid balance should incorporate enteral and parenteral nutrition, and fluid removal by CRRT needs to be adapted. Then what is the best method to estimate calorie need during CRRT? Then indirect calorimetry that should be performed and measured required energy and calorie requirement should be used as a target without correction factors. So indirect calorimetry, we should give calories of 25 to 35 kilocalories per kg body weight per day. to the patients and on the CRRT with the protein of 1.5 to 1.8 gram per kg body weight per day, simultaneously to replenish the electrolytes, glucose, and other vitamins and trace elements. So, for the CRRT, there are this quality control system, which includes mainly three domains like structure, process, and outcomes, which can help us in preventing the dialytrauma. So in structures, so we can have quality indicators like the providers. There should be specialized expert team, and its assessment for the CRRT, the education and training program. The prescription should be like depending on the modality, blood dialysis, ultrafiltration flows, fluid loss, anticoagulation. The process, prevention of the patient's complications like fluid overload, hypovolemia, hypotension, bleeding, dialysis, catheter-related infection, hypothermia. Then performance like delivered and prescribed treatment, filter lifespan, then duration and causes of downtime, duration of effective treatment, and we can assess the outcome in the form of prognosis in the term of survival and recovery of renal function. So as we have seen, there are multiple complications can happen if not attended properly during dialysis, in view of dialysate contamination and the composition errors. Then there will be complications related to vascular access, as we have studied in the last lecture. So for the vascular access for the renal replacement therapy, the guidelines suggest that initiating the renal replacement in patients with AKI via an uncuffed non-tunnel dialysis catheter rather than the tunnel catheter. They also suggest the use in descending order of preference, like right jugular vein, then femoral vein, then left jugular vein, or the subclavian vein for the insertion of dialysis catheter in patients with AKI. They also suggest use of ultrasound guided dialysis catheter insertion. They recommend obtaining a chest X-ray after replacement and before the first use of catheter. They do not suggest use of topical antibiotics over the skin insertion site or for the non-tunnel dialysis catheter in ICU patients. They do not suggest antibiotic locks for the prevention of catheter-related infection in the dialysis catheters. So another complication we can prevent is venous air embolism that we have studied in the last lecture. Then intradialytic hypotension, the risk factors for this hypotensions are left ventricular LVH with diastolic dysfunction, then valvular heart disease, pericardial disease. I'm not going in detail as we have discussed in the last seminar. So managing intradialytic hypotension is also important to prevent the dialytrauma. And temperature regulation. This higher CRRT doses are associated with higher incidence of hypothermia, and short-term cooling may be beneficially affect the hemodynamics and outcome in the ICU patients. So how we can manage this dialytrauma? So the problems and strategies. So circuit-related coagulopathy, then we can prime or proper vascular access, blood flow at least 200 ml per minute or more. Then use of citrate-based regional anticoagulations on a standardized protocol with strict sodium, calcium, and buffer control. For the irregular drug dosing, as we have seen, we can monitor the plasma level, and we can adjust the empirical dose, loading dose, and the maintenance dose accordingly. For the loss of vitamins and trace elements, we can daily supplement. We can supplement the water soluble vitamins. Then vitamin E and K should also be supplemented. Um, Vitamin A dose needs to be reduced, and the additional doses of micro nutrients like selenium and thiamine should also be supplemented. For the fluid management, fluid balance into the general chart, balance of the patient, so that there should be always negative fluid balance can be sustained with 2-hourly modulation of the chart fluid balance. For the electrolyte imbalance, we can correct this hypokalemia. For the hyperkalemia, fluids without potassium can be used. For the hypophosphatemia, we can use phosphate-rich dialysis fluids, and for the hyperphosphatemia, we can use phosphate-free dialysis fluids. Acid-base imbalance, we can use fluids with bicarbonate for the acidemia. For the loss of nitrogen, we can increase the amino acid supply by 0.2 gram per kg per day. For the heat loss, in case of longer duration of the cooling, we can aim body temperature to maintain less than 37 degrees Celsius, either by external warming or incorporating renal replacement therapy heating systems. For the hemodynamic monitor issues, we can reduce the blood flow to 100 ml per minute along with the stopping fluids during transpulmonary thermodilation or any other dilution techniques. For the issues of vascular access, we can use USC and strict anti-sepsis. That's about the dialytrauma. So, in nutshell, the CRRT, even with this multiple benefits, has always has some complications, and we can avoid that.
So can you little bit of summarize that what we can take home, that what is the concept of dialytrauma and how we can mitigate it or prevent it? I think do we have Das sir or Shatarupa also? Yes. Dr. Das is here. Das sir, any comment on this? Yes, sir. Thank you. Thank you.
Nicely covered. It is a new concept actually. I also didn't know at that point of time what is meant by dialytrauma. This is a new basically word which has coined, and it has been incorporated in my mind today itself. Thank you, Sital, for this information what you gave.
Sir, thanks to Arindam sir, because sir provided me the topic and the material to read about it. So even I can also read about it and know about it.
Yeah. So the practical aspect, there are lots of theoretical aspect you have mentioned about it. Okay.
Yes, sir.
So the practical aspect.
Yes, sir, the practical aspect we want to know, that what could be the practical usefulness of this concept. Sheetal, you can stop sharing.
Yes, sir.
Let us see each other. Yeah. Okay.
So
yes, sir. Carry on.
So one is the dosing, drug dosing, what you mentioned nicely, that it could be underdosing, and if it is a overdosing, then it can cause harm. If it is a underdosing, then it can cause more of harm to the patient in the sense that the minimum inhibitory concentration could not be achieved. So it is a very delicate balance, and especially so when a patient is in ICU, critically ill, who is basically bedridden, not moving his limbs or body. is dependent on others to move the body. Many a times they are on ventilatory care, multiple drugs, uh, especially the inotropic drugs. So the true nature of the concentration of antibiotics or any drugs reaching the patient in adequate amount is really difficult to assess. There are a few pointers to it. One is the volume of distribution of that drug itself. If the volume of distribution, you know about the any drug, if it is a narrow therapeutic window with less volume of distribution, then you can achieve that concentration in if you are giving an intermittent bolus form. However, the problem is if the drug is having much of higher volume of distribution. So what I meant in volume distribution is whenever you are seeing a normal patient who is not critically ill, the volume of distribution is different. And when a patient is critically ill, the volume of distribution is different, and it is very difficult to assess that. Since many a times they will be hypoalbuminic, they will be having more of interstitial edema and intravascular volume depletion. You will be seeing edematous state, but the intra-arterial blood volume will be low, especially so in multiple organ damage scenarios. And also if the patient is having chronic liver disease or nephrotic syndrome or like that. So it is a tricky situation. So you have to know what is the volume of distribution of the drug and what is the protein bound nature of that drug, whether it is antibiotics or if it is a other drug which you are using. So more the protein bound, less will be removal from your body or by the CRRT. So obviously it will be circulating inside. So for example, one question always is pertinent to ask whether in phenytoin toxicity, dialysis or CRRT will help, when we know that in one of the charts you have given that the phenytoin toxicity is a highly protein bound molecule. So if you go into the literature, there are controversial things written about it, or it has not been yet clear to us. But it is clear from that literature that when the phenytoin binds to the protein, it has got a maximum ability to bind, and beyond that it will be in the non-bound form. So in case of phenytoin toxicity, our aims and objectives will be to take out the non-bound form in the initial period, which could be potentially causing more harm, more tissue damage. So that is the concept of doing dialysis in phenytoin toxicity. Whereas, during that period of time, those drugs which are bound to the protein or albumin will be liberated from the protein, since it will not completely bound. No, it is a reversible binding. So it will come out to the bloodstream, and during that period of time, if you take it out, then gradually the level of concentration of that drug will go down. So the concept of that is basically that in spite of protein bound nature, we sometimes uh, go for CRRT for removal of those molecules which are in the not bound form. Okay. So my emphasis is basically volume of distribution, protein bound nature, and what should be the drug dosing. Pharmacokinetics can be done, but it is bedside practice is not so much, it is in experimental stage. Still, I think it takes, if you say send a vancomycin level, then it will come maybe 3-4 days after, and it will be of no use to us at that point of time. So that is one. I think my concern I have already addressed to. Any other person, Rishi, if he is there, then he can also give some tips. Arindam, any question, any other, whether I have given
No,
some.
sir, I think you have spoken on that part. Only other thing is that the phosphate clearance. I was intrigued about that part. Does it play a major role in AKI, particularly in critically ill patient? I'm not talking about the CKD persons, because hypophosphatemia could be a problem in AKI patients who previously didn't have CKD, right? And that can have certain repercussions on your what we call the muscle sort of strength, vitality, to some extent, some sort of cardiac destabilization and others. So how to deal with that?
Yeah, very nice question, Arindam. Whenever we are doing CRRT or SLADE, we are basically using high flux membrane. And when we are using high flux membrane for longer duration of time, the phosphate clearance increases. So phosphate clearance is dependent on the duration or time. So longer the duration, phosphate clearance will be better. So that's why quite frequently we see hypophosphatemia in those group of patients if they are not given adequate food replacement in return. And they are also can be in catabolic state where the protein catabolism is much more higher, and that also will contribute towards lowering of the phosphate level and other things. So what we used to do is that is not applicable for CRRT, but for SLADE, we add fleet enema to the dialysate. Fleet enema is not available here but phosphate enema is available. We can add actually in to the dialysate A part phosphate substitute, and then see how much is there is a formula for that, and we can increase the phosphate level through that. And besides that, we can also you increase the dietary phosphate intake in the form of dairy products and other things, which will be beneficial both for protein calorie malnutrition and also for giving phosphate to the patient. Another phosphate release is probably happening due to the immobilization of the patient. So the bone, from the bone itself, calcium and phosphorus can get mobilized to the bloodstream, and during dialysis, it can get just lost from the body. So overall, there is definitely a negative phosphate balance if you are doing dialysis for a long time. But the trend is basically that if you are giving calcium and phosphorus together, then it is a deadly combination. Since calcium and phosphorus, both IV, if you are giving, then it can bind with each other and cause deposition in the endothelium and cause more of, and in presence of uremia, it can cause deposition and cause more of vascular calcification. So that is the fear, that we should not be supplementing in very high dose. Arindam, any?
Yes, sir.
I think I have addressed the question.
The other thing is that one of the concept of dialytrauma is that maybe due to the removal of important molecules and medicines, that are we underdosing in CRRT? So the last comment on it, sir.
Yeah, underdosing, I think that is what, no, in that scenario, there are recommendations. Since we cannot do pharmacokinetic studies, so there are recommendations of how much antibiotics and any other drugs to be given during CRRT or SLATE. And those are extensively, they have done the study. And although those are all literatures from the Western, but I think we can utilize those. I've said in one year that there is a, for antibiotics especially, that Taraxon Pharmacopoeia, they have a CRRT concept. Then there is another Aronoff book is there, which is which gives all the major medication related, how much will be the dosing related to it. And however, there is a what you said is, besides the dosing, there is a concept about whether we are removing good cytokines. Bad cytokines we are taking out, but the good
Yes, sir.
cytokines, whether we are taking out and we are causing more harm to the patient. So those controversies will remain. I don't think so that can be addressed in short duration of time, unless until we have a nanotechnology which can give some answer to it. So nowadays there is a concept they are called telling is that it is a like a pore bank or that is the pore bank model. What is that pore bank model? It is basically like in the bank you are keeping your money and you are taking out small amount or large amount as per your requirement. So let us say that you want a cytokine removal. So larger pore dialyzers can be utilized, and those can be done by the nanotechnologies. Okay. The other thing is that if you don't want the cytokine to be removed, you want the solute to be removed only, then you can use a smaller pore size of the dialyzer rather than just utilizing the dialyzer, which is one dialyzer fit all model kind. That should not be practiced. So current practice, basically the thinking process is that whether we can utilize a model that will be with this pore bank technology. And there is another thing is, whatever the dialyzers we are using, those are, although these are synthetic or semi-synthetic dialyzers, the pore size is different in all these dialyzer, and they are disproportionate. Means one dialyzer will be having multiple pores, with multiple size, and they are not straight like the tube. Those are curved. Those can be bent. The pore from one side, like the blood from the uh, blood compartment to the dialysate compartment, could be curved, could be having some size will be different in different place of the dialyzer. So that causes difference in solute clearance as well as cytokine removal. Since there will be a resistance, whenever there is a uniformity is not there, it is like a tube. If you say that inside a tube, capillaries, the pores are like a tube inside that will be connecting the blood compartment and the dialysate compartment. So the nanotechnology will cause, when applied, it causes straight tubes which will be having less resistance, and you can manufacture dialyzer with certain pore size. That is the pore bank concept. So now probably in next few years, we'll be seeing that if the cytokine is high, then the recommendation for different dialyzers will be in place. Besides what we are using, like cytosorb and others filters. So that addresses the question, Arindam.
Yes, sir.
Okay.
I will have a word with you. Thank you.
Okay. Thank you.
Thank you, sir.
Thank you, sir.